I will present you Professors Vincenzo, Iorio, Siciliano, and Andrea Blasi. Vincenzo Iorio Siciliano qualified from University of Naples Federico II in 2004, and he was a general practitioner until taking a PhD in periodontology and implantology in 2009. He is a specialist in oral surgery since 2006, and he works as a visiting scientist at the University of Bern, Department of Periodontology, with Professor Lang, and actually with Professor Sculan. Since 2005, he was assistant professor at the master course on periodontology and implantology at the University of Naples. In 2011, he was postdoctoral research fellow, and also he's an active member of the Italian Society of Periodontology and Implantology. He has published papers in the Journal of Periodontology, Clinical Oral and Implant Research, International Journal of Oral and Maxillofacial Implants, JOMI, and International Journal of Periodontics and Restorative Dentistry. By his side will be his colleague Andrea Blasi, who is also assistant professor at the Department of Periodontology at Federico II University in Naples. He obtained his PhD in dental sciences in 2009. He obtained a Master of Science in Oral Surgery in 2017, and he's now an assistant professor at the Department of Periodontology. We can see them both, hello, in their webcam. So I give the floor now to you.
Thank you very much for the introduction. Dear colleagues, good morning. It's a very great pleasure for us to be here with you. And in the next 30 minutes, I would like to discuss with you in cooperation with Professor Blasi. We talk about on etiology and risk factors of peri-implant disease. Nowadays, the implant reconstructions are considered the best solution to treat the edentulous sites, to edentulous ridge. And you can see the long-term prognosis of this implant reconstruction after 13 years observation time. After 13 years follow-up, a gingival recession at the buccal site of the first premolar was recorded and treated by means of a chorally advanced flap in combination with the connective tissue graft. And this is the healing of gingival recession covered with the new gingival tissue after 1 year following the treatment. And the case, the clinical and radiographic view after 18 observation time. And this is another case of an implant placed in augmented site. You can see the presence of milk tooth with hypermobility. The milk tooth was extracted, and after granulation tissue removal, the fresh alveolar socket was managed using a combination of bovine bone mineral covered with the collagen membrane. Then a connective tissue graft harvested from the palatal site was used to cover the membrane, and a temporary reconstruction was used at the end of the surgical procedure. After 6 months healing, this is the soft tissue healing and hard tissue healing when an implant was placed in a three-dimensional correct position. After 6 months, a first temporary crown was used to manage the soft tissue around the implant. and finally prosthesis reconstruction after 1 year observation time. This is the comparison between the baseline situation and the clinical situation after prosthesis reconstruction. She's the patient after 3 years of observation time. You can note no signs of inflammation and no marginal bone loss from radiographic point of view. The patients after 4-year observation time and then after 10 years observation time. We did not record any problems. The soft tissue integration is perfect. As you can see, the X-ray exam showed no sign of marginal bone loss at mesial and distal side. For the first time, the expert in periodontics during the World Workshop in 2017 proposed a definition of peri-implant health. And clinically, we talk about peri-implant health when we have absence of visual sign of inflammation and absence of bleeding, unprobing, and separation. But unfortunately, it is not possible to define a range of probing depth compatible with peri-implant health because depend on the implant shoulder position and depend on the depth of a mucosal tunnel. But if bleeding on probing or suppuration are recorded, in this case, we can diagnose an inflammatory lesion in soft tissue surrounding an endosseous implant. And in this case, we talk about peri-implant mucositis. Clinically, the peri-implant mucositis is characterized by the presence of sign of inflammation, bleeding on probing, and the presence of suppuration. But we do not record the marginal bone loss at mesial and distal site. The cause of peri-implant mucositis, the peri-implant mucositis depend on the accumulation of biofilm around dental implants and around the prosthesis reconstruction. And from a clinical point of view, the peri-implant mucositis differ from the gingivitis, because the healing of this type of inflammation is possible at clinical and biomarkers level. But with respect to gingivitis, a longer healing period is needed in order to obtain a peri-implant mucosal health, at least 3 weeks. And this is a case of peri-implant mucositis. You can note the presence of marginal soft tissue inflammation, but from a radiographic point of view, we did not record a marginal bone loss. And after treatment by means of a mechanical instrumentation, a perfect healing of soft tissue around the implant was observed. It's very interesting to discuss the next clinical case. In 2009, I placed an implant in pristine bone, a transmucosal implant, and after the surgical suture, after 6 months, the prosthetic crown was cemented. But after 4-year follow-up, mucosal inflammation, peri-implant mucositis was diagnosed. After treatment, we have obtained a complete resolution of peri-implant inflammation. But after 5 years, we diagnosed a peri-implantitis. You can see an increase in probing depth and a vertical defect at the distal site of the implant. This peri-implantitis was treated by means of a surgical approach using an regenerative therapy and healing after 1 year observation time and you can note the complete bone filling of this defect. Another case, an implant placed in 2006. After 9 years, a peri-implant mucositis was recorded. And after untreated peri-implant mucositis, following 1 year, a peri-implantitis was recorded with consequently implant bone loss. This clinical case is in agreement to the findings of a study conducted by Costa and co-workers that observed that after 5 years observation time, peri-implantitis was recorded in 56% of the implant with peri-implant mucositis. But in case of soft tissue inflammation is associated with the marginal bone loss, we can diagnose as peri-implantitis. Peri-implantitis is characterized by the increasing protein data as compared with the PD values collected after placement of prosthetic reconstruction. But in absence of a previous documentation, we consider a peri-implantitis. We can diagnose a peri-implantitis using the following parameters: a marginal bone loss greater than 3 millimeters in combination with bleeding bone probing, and probing depth greater than 6 millimeters. Now I would like to introduce Professor Andrea Blasi for the treatment of peri-implant mucositis and for discuss the risk factor related to peri-implant disease. Please, Andrea.
Thanks a lot. So, hello everybody. Sorry for the delay. So, then again, as my colleague told you, it's crucial to prevent and to treat early the mucositis in order to prevent major problems as peri-implantitis. So the goal is to resolve mucositis, which means resolving all the BOP sites, all the sites with BOP. And then we can see in this case, at 6 months, we obtain the resolution of the bleeding on probing. But how can we obtain this in this RCT from Heights Mayfield? We can see that complete resolution of the inflammation by mean of non-surgical approach was achieved only in 38% of the treated implants, which is a very low standard. And also the other RCTs that try to evaluate the treatment of peri-implant mucositis with different approaches fail to obtain a complete resolution in all the cases, and also have obtained very low standards. So we propose this study in order to evaluate the effect of the adjunctive delivery of sodium hypochlorite gel for the treatment of peri-implant mucositis. And we had a test group with non-surgical treatment together with sodium hypochlorite, and a control in which was used non-surgical therapy plus a placebo. Both failed to obtain 100% of resolution of the bleeding on probing, which means that also in this case sodium hypochlorite is not as effective as we expected. Since it's hard to completely resolve the mucositis, it's interesting to spot on the risk factors for mucositis. And this systematic review from Rembert has found out some of the possible risk factor for peri-implant mucositis. And analogically as was made for treatment of peri-implantitis or of periodontal disease with the PRA and IDRA and implant disease risk assessment was proposed by Heiss Mayfield in 2020. Differently from the PRA, there are not only clinical parameters like BOP, PD, and PD measure or equal than 5 millimeters, bone loss per age, but also history of peri-susceptibility of the patients, which means grading and staging of the patient of the disease, and the compliance of patients for supportive therapy, but also, and this is the main difference, the design of the prosthesis and the RM bone value, the radiographic marginal bone loss. As we're going to spot on the history of periodontitis, we see in this patient awful periodontal conditions. It was treated. It was we aim to before we start with the implant therapy, we aim to solve all the defects. First with non-surgical therapy, and then by a surgical approach. And after the periodontal disease was put under stable conditions, we decided to place an implant to replace the missing tooth. And we see in surgery. And at 2 years, we can see a 2 years follow-up. The implant is healthy. And so at 6 and at 10 years. And this is also confirmed by the research that we, as a team, and together with Professor Giulio Rasperini and the University of Bern, with the researchers that we brought on for the implant therapy in periodontal patients. And we see that the implant therapy is a reliable therapy also in patients with history of periodontitis. But we can see in this case, everything was, we placed these implants in 2004, everything is fine in 2005, everything perfect in 2011. So we can see that everything is good. We relax? No, not yet, because in 2014, we have some signs of mucositis on this implant, and it was treated non-surgically. Signs of mucositis on this other implant also treated with non-surgical approach and resolved. But here we have some bone loss. So in this case, we have an initial form of peri-implantitis, and we treated this one with sodium hypochlorite gel, cleaning and sodium hypochlorite gel delivery. And we managed to solve the defect. At 6 months, we can see that there is no more probing around this implant. So don't relax too much in these patients, but this is the follow-up in 2022 after 18 years, and everything is perfect. Peri-susceptibility of the patients, which means according to the new classification of periodontal disease by stage and grade of the disease, we can see that these patients with a stage 4 grade C periodontitis was treated, was cleaned before, and was reevaluated. This is a major case. There are also some prosthetic and endodontic problems, and we try to fix them. And an implant was placed. Treatment, the periodontal treated defects were treated, both non-surgically and surgically, as we can see. And the furcation was treated and resolved, and with the root extraction, with resectomy. And here again, prosthesis. And we can see that in 2014, situation was good, was everything under control. So that we decided in 2015 to place another implant distal to the first. Everything looks fine. At follow-up at 4 years, everything was good. But after 8 years follow-up, we have some signs of peri-implantitis of mucositis on this implant. So also never relax too much. Always keep an eye on these patients. Compliance of the patient with supportive periodontal therapy is a major issue. And of course, needless to say that patients which adheres to our protocols is of course under control. It's way less susceptible of showing up mucositis. Distance from restorative margin to bone is evaluated radiographically, is very important because we can see that a very long transmucosal space, it's a risk factor for mucositis, as shown from this study from the Tonetti research, from the Tonetti research group. And so if we want to improve the aesthetics and the soft tissues around the implant, as we can see, this one is beautiful. The soft tissues are beautiful, but please don't do it by increasing the crestal level of the soft tissues. Just place the connecting graft vestibularly, as we did in this case. See, connecting graft, and in this other case as well, we have this defect, vestibular with a concavity. Okay. So while placing the implants, we took a graft from the palatal side of the wound, and we put it vestibularly, and everything is perfect. And a follow-up, no problems. Okay. Let's focus also on the prosthesis. Of course, prosthesis which is not cleanable or not adequately cleanable by the patients is a source of biofilm accumulation and then a risk factor for mucositis, as shown by this research by Takamori, where you can see that implants without an adequate access to interproximal hygiene were associated with implant failure. And as shown by Sanz, if the prosthesis is changed in these implants, we have a resolution. We can achieve a resolution of the lesion. Oh, sorry. Okay, you see this? It's better now? Okay. Also, as well as lack of interproximal space, too much interproximal space is a risk factor from the prosthesis, because we have, as in teeth, a food impaction, and then again, a risk for mucositis. And also an emergence profile with a degree of major or equal than 30 degrees is a risk for mucositis and peri-implantitis. It's a risk factor for mucositis and peri-implantitis. And we see in this case, we have these implants with lack of adherent gingiva and loss of bone and incorrect and incongruous prosthesis. So we decided to treat these implants by connective tissue graft first in order to recreate the adherent gingiva. And then we proceeded to treat the implants and the bone defect. We had a plastic of the implants, of the extra of suprabony, of the suprabony aspect of the implants, and which were polished, and a regenerative approach with the infrabony portion of the implant. A new prosthesis And this is the follow-up. We can see that we have obtained a very good result. Maybe not aesthetic, but it's in the posterior area, so it's very, very achievable, very comfortable for the patients. So we have spotted on the of the risk factor of the included by the Hydra for preventing peri-implant disease, and I would like to leave the final remarks to my colleague for the conclusions. Thanks again.
Thank you very much, Andrea. Then I would like to conclude our presentation. In conclusion, we are very happy to show you a clinical case of the implant with a long follow-up, a long prognosis. But unfortunately, the implants are not free by complications, such as peri-implant mucositis and peri-implantitis. For this reason, I prefer to show you this type of clinical case, a natural treat, a patient with the past history of periodontitis treated and maintained for many years. Thank you very much for your attention. Thank you very much, Dr. Constantinescu, for the kind invitation.